Good morning, everyone. I'm Bob Challoner. I'm the President and CEO of Southampton Hospital, and I'd like to welcome you this morning to our public awareness event about tick-borne diseases. And I will be introducing a wonderful panel of presenters, people who have been working with us on our Tick-Borne Disease Resource Center at the hospital for a number of years now, and have graciously given of their time not only today but at multiple events throughout our region. Little bit of background for all of you about the Tick-Borne Disease Resource Center at Southampton Hospital. Our physicians a number of years ago, and particularly in our emergency room, began telling us about the influx of patients that we were seeing in the hospital. People coming in not only to have ticks removed, but with various diseases, and not just the disease we always hear about, Lyme disease. And through discussion with our medical staff, realized that there was a need for something, that the hospital had to do something for the community, because it seems to be a growing issue for this community on the East End. And I've said this at past events, and I will say it again, that I believe that what we are seeing is a public health crisis, that the amount of exposure to tick-borne diseases is increasing throughout our region, and it's very unfortunate because it's a community that thrives on the outdoor life, and we want people outdoors and enjoying our environment, and yet they are increasingly being exposed to ticks. So the hospital felt that there were three things. If we approach it from the perspective of a public health crisis, the most important way to combat any public health issue is through better education. And we heard stories of people talking about their home cures for tick-borne diseases. Some friend told them how to remove a tick in ways that frankly were unsafe and likely to complicate. So we began with the notion that we need to get better education out. So from those discussions, the Tick-Borne Disease Resource Center was born a number of years ago with really three missions. Mission number one is to educate, and educate not only the public and get you the best evidence-based research, and we stress that nothing our speakers will focus on is not backed up by good research, from university settings, and trying to avoid the sort of fad things that we hear out there. So we want to make sure that we get you good access to good information. We also want to make sure that we get our clinicians. Many of our own nurses and doctors were asking questions, what do I do? What is this? What is this new disease we're hearing about? So in addition to public sessions like the one we're having today, every year we have a number of sessions that are specifically for physicians and nurses and clinicians where they can ask questions and get into the science of what we're learning about tick-borne diseases. And we're also making sure that we're staying current, because I'm a lay person, but I certainly have realized that over the last number of sessions, and I've been to a lot of them, that the research is growing, and frankly it's a much more complicated field than I think many of us realize, and you'll hear a little bit about that today. So education is an important part of what we're doing. Number two, we want to help you get resources. We decided against the notion of trying to create just one single point center where people would go for treatment, but rather learn about all the resources that are out in our community and elsewhere, and create navigator services. And we do have, we established a helpline, 631-726-TICK, that's 8425. And that is staffed by an excellent, well-trained nurse, Rebecca Young. I'm hoping she's here today. Rebecca's in the back of the room. Hi, Rebecca. Rebecca is taking calls from all over our region, frankly all over the country, and we've even had calls from Australia looking for help and advice. So Rebecca's job is to get people to the appropriate experts. And then finally, we felt that we could help support the research efforts that are going on to try and combat this issue. And you'll hear from one of our speakers today about some of the research we are supporting locally. We are not doing the research, but we are supporting the research. We're certainly a hotbed for people who have been exposed to ticks, and good research requires research subjects. And we've been working with a number of universities, including Stony Brook, to further their research goals. So those are the three missions that we set out to accomplish. In the time frame that we've been in place, in the last year we took 428 calls on our tick line. That was a 46% increase. This year, I understand, we are already in the first few months of the year ahead of last year's entire year numbers, and this is a very, very bad year. You'll hear about that from one of our speakers. I thought it was my own personal story I'll share. About 2 weeks ago, about a month ago, I was bitten by a tick, found it in the middle of my back, and about 2 weeks ago, my partner noticed a rash blossoming across my back. So I'm actually on doxycycline as we speak. So I have a very personal exposure to these diseases. We are all running into it. We've started outreach to the adult community. We started in February this year. We've already done 25 events for adults, and we're reaching hundreds of residents and visitors. We also have a very significant outreach to kids with a program called TickWise, sponsored by Brian Kelly, who has been very, very supportive of our efforts of East End tick and mosquito control. And Brian, we've been working with a teacher, April Boitano, who's developed a curriculum to teach children, and we've been out into the schools and trying to reach all of our children in the area to educate them about tick exposure. We've got a number of resources for you, which we'll hand out at the end of the program. The educational materials. We also have a tick kit, which our generous donors have been supporting. Please take one, bring it home. Learn how to remove a tick correctly. You'll hear that is absolutely the best thing. You will eventually, if you live out here and spend any time outdoors, be exposed to a tick, and hopefully you will learn how to remove the tick correctly. Those tick kits are free. Everything we are doing is free of charge. We believe that this is something that it's our mission and part of what the hospital needs to do to be out there helping you. We will, of course, and I will make a pitch, anybody that wants to write us a check and support our efforts with this, we are very happy to accept those. It does take money. Our speakers are donating their time, but developing the education materials and supporting this effort does take money. So if anybody is so moved, please feel free to help our efforts. And now what I'd like to do is introduce our speakers, and we do have a wonderful panel for you today. And we'll go in order of the agenda. We will ask each of the speakers to speak, and we will save questions until the end. So there are, I believe, pads and pens here. If you think of a question, just write it down, and then we will have ample question and answer opportunity at the end, and we'll talk about that when each of them are done speaking. So let me introduce our first panelist. It's Dr. Scott Campbell. Scott Campbell is a medical entomologist who received a Bachelor of Science from Muhlenberg College and a PhD from Cleveland State University. Currently, Dr. Campbell is the laboratory chief of the Arthropod-Borne Disease Laboratory for the Suffolk County Department of Health Services and has been involved in public health and research of arthropod-borne diseases for approximately 25 years. He and his staff are responsible for countywide surveillance for all mosquito-borne and tick-borne pathogens that cause human disease. Dr. Campbell is a member of various professional organizations, enjoys presenting at professional meetings, and has contributed to the scientific peer-reviewed literature. Dr. Campbell.
Thank you. Good morning, everyone. So what I'm going to do is I'm going to talk about the entomology of ticks and the tick-borne pathogens. And it's important to kind of understand ticks and the pathogens they carry to better prevent tick bites, as well as to make medical decisions on how to treat possibly or what you may be exposed to. So hopefully it will go well. So in Suffolk County, or on the East End, there are basically 3 tick species that are of medical importance. The first one is the black-legged tick, or also known as the deer tick, Ixodia scapularis. The American dog tick, Dermacentor variabilis, and the third and newest comer to Suffolk County is the Lone Star tick, or Amblyomma americanum. So the life cycle of a tick is basically from egg to larva to nymph to adult, and it takes about 2 years for these ticks to go through that life cycle. And obviously between each stage, they need a blood meal, and they ingest that blood meal and they molt into the next stage. Adults, they don't survive past the adult, they die. The males mate, and the females lay eggs to create, obviously, the next stage, which will be the larvae, and continue the life cycle. So ticks, they don't drop from trees, they don't fly, they don't jump. All they do is they come up from the ground, from the leaf litter, whether it's on vegetation or on the leaves, but they quest. And the questing is basically where they put their front legs out and they wait for a host to come by. Some are more aggressive with questing. Some will actually pursue, like Lone Star ticks will actually, if they catch a CO2 plume from exhalation from you or your dog or cat or deer, they will pursue that, and they can walk up to several yards to a potential host for a blood meal. But again, they come from the ground, not from above. So the blood feeding, as I said, serves 2 purposes: nourishing, so they can molt to the next stage, or for the females, it allows them to create the egg mass and lay the eggs, which are generally about 2,000 to 4,000 eggs are typically laid by an engorged female. So this is the black-legged tick, and as I said, the 3 stages are there. The larva, which emerges from the egg. The larva feeds, molts into the nymph. The nymph feeds and molts into the adults. So the larva and the nymph of all tick species are asexual, whereas the adults obviously mate, and the eggs are laid. So this is a lot of peaks, but what it shows is when the different stages are active. And you can see that for the black-legged or deer tick, they are active all year long. So you can be bitten by a deer tick at any time during the year. Adults come out in the fall, and they basically are gone by the spring, and they are active whenever the degree day is above 40 degrees. But you can have microclimates too. So the temperature outside can be 35, but on a south-facing slope, it can be 40 or 45. So typically, they will be active when those temperatures are around 40, and then we obviously are subjected to possible exposure to this tick species. So the pathogens that they carry, they carry quite a few. The first one is Borrelia burgdorferi, or the agent that causes Lyme disease. And I'm not going to go into much detail about these pathogens, but I just wanted you all to know what they carry. But almost everybody knows the spirochete. The other one is human granulocytic anaplasmosis, or Anaplasma phagocytophilum. Again, this is a bacterium. just like the spirochete, and as being a bacterium. Babesiosis, however, Babesia microti is actually a protozoan, very much like malaria. So you have the symptoms much like malaria with the fever, episodic fever. And then the one that's been around for a while, but currently in the press and everybody's talking about is Powassan virus. This virus is found in Suffolk County and in the black-legged ticks, and at very low rates, and that's why we don't see it in the humans as much. But again, that's a virus. So the life cycle, the primary hosts for the black-legged or deer tick are the white-footed mouse, and the juvenile ticks typically feed on the mice. The mouse is the reservoir for those pathogens. So they have to feed on a white-footed mouse to pick up Borrelia burgdorferi or Anaplasma or Powassan, the pathogens that I talked about. So they need to feed on those mice. They have to be infected to gain that pathogen. So if it's a larva that feeds on an infected mouse, that infected larva molts into an infected nymph, feeds on an uninfected mouse, and can infect that mouse. So it's kind of a tennis match back and forth between mouse and tick to increase the infection rates of those pathogens. The deer are important. They're like the keystone species for the life cycle. The adults primarily feed on deer, so they're important for driving the population levels, not the pathogens, but the populations levels. Where you don't have a lot of deer, you have lower tick populations. So the American dog tick, this is a male on the left, female on the right, and they've been around for quite a while, those that have lived here for decades. This was the tick that was in the 70s and 80s, and I'll explain why that there's been a slight change in that. But the things to remember with this tick is that the juveniles are very, very restrictive to biting rodents. So you rarely have larvae and nymphs biting humans of this tick species. So it's the larger ones, easily found. Obviously, the larger the tick, the easier it is to find when it comes to tick checks. And they come out in spring, and probably by July, August, they're gone. So they're the ones that come out in April that a lot of people will find if they're in that kind of habitat, which we'll talk about. Vectors are primarily two pathogens: Rocky Mountain spotted fever, Rickettsia rickettsii. And again, the number of cases of Rocky Mountain spotted fever are going down because this tick the population is going down. Tularemia, it's also a competent vector of tularemia. Again, both of those are bacteria. Now this tick feeds on meadow voles, and that is the competent reservoir for Rickettsia rickettsii. So again, very similar life cycle, but different hosts that are reservoirs, or they're able to hold those pathogens in their body. They just circulate in the blood. There's no ill effect to the rodent, and they kind of live in a happy symbiotic relationship. All those three components: the tick, the rodent, and the pathogen. So juveniles feed on the rodents, as I said. The adults feed on canids, canids like fox, dogs, humans, some other hosts as well, but typically fox. So the next tick is the Lone Star tick, Amblyomma americanum. Now these are important. All four stages will bite humans, and larva, nymph, and the two adults. So if you look at the activity of this species, the nymphs and adults come out in the spring, about the same time that the American dog tick comes out. And so you can see that double line in the beginning. Now in the summer, the larvae start to come out. And this is what is referred to as chiggers, which is a misnomer. Chiggers are actually a mite that we don't have biting people on Long Island. But so if you have those red rashes in August and in the early fall, you're being bitten by the larval Lone Star tick. The tick bites, drops off, those red bumps, there's nothing under them. It's a reaction to the bite. So if, I've heard some people, they treat it, they put something over top to suffocate the chigger. That's incorrect. There's nothing there but the bite. The tick is long gone. And oftentimes you'll find ticks when they feed, you'll find them in bed. They'll drop off when something's resting, whether it's a human or a dog. You'll find them in dog beds. So the pathogens associated with the Lone Star tick is Ehrlichia chafiensis, or human monocytic ehrlichiosis, again, another bacterium. Southern tick-associated rash illness. At one time, they thought it was Borrelia lone stari, another spirochete, very similar to Borrelia burgdorferi. They've kind of backed off of that. They see the rash after bites from Lone Star ticks, but they're unsure exactly the pathogen. And then they are also competent transmitters of tularemia, Francisella tularensis, another bacterium. Now, the Lone Star ticks are a little different. They really prefer deer on all stages if they're not biting a human. They will bite deer. So larvae, nymphs, and adults are very dependent on deer. And so, again, where we have healthy, large deer populations, we generally will have healthy, large Lone Star tick populations. Lone Star ticks started on the East End around Montauk in the 70s, maybe a little earlier, and have been slowly moving west, and their border is between Babylon and Huntington currently. And so what they're following is the growing deer herd. The deer are moving west as well, and following it are the Lone Star ticks, as well as the deer ticks. And also the deer are the reservoir for Ehrlichia chafiensis. So again, the tick habitat, I alluded to this earlier. It's very important because you have to kind of understand where these ticks are going to be to prevent tick bites. So blacklegged or deer ticks, they prefer woodland areas because they like moist leaf litter. So they need to rehydrate frequently. They're not very, they're prone to desiccation. So if you keep your yard sunny and dry, the chances of finding deer ticks in a dry, sunny yard are a lot lower than some of the other ticks that don't have a problem with desiccation. So you find them in the woodlands. Now the American dog tick is a meadow vole. They prefer meadows or grasslands where the meadow vole is. And if again, you've been around Suffolk County for a while, a lot of those meadows are now either secondary growth forests or homes. And so we've seen a big change, an ecological change, with regards to the meadows that used to be in Suffolk County, and that's why we're seeing fewer and fewer Rocky Mountain spotted fever cases, because we're seeing an ecological change and fewer American dog ticks. Now the Lone Star tick, they love it all. They can be found anywhere. They can be found in woodlands, grasslands, that secondary growth, disturbed growth, and even on your back porch. I mean, they'll come into your pool area. They'll come into, again, they're the active hunters. So they'll come in, if they can sense a CO2 plume, they will actually come on your porch or on your pool deck or on your lawn chair that's sitting in the backyard. But they're not prone to desiccation, so they can be found anywhere. So, as I said, it's important to understand the entomology to try to prevent. Right, we know they don't come from the trees, so they come from the ground. You want to create a barrier to prevent tick bites, and there's two ways to prevent barriers. One is clothing, and the other is repellents. So if by by dressing properly, long pants, long sleeves, and then maybe treating those clothes with repellents, and maybe exposed skin with repellents. You have those two barriers. Obviously, the best way to avoid ticks is stay out of the tick territory, right? But that's no fun sitting in front of the TV 24 hours a day, right? You got to get out there and enjoy the wilds that Suffolk County has to provide. So you want to stay away from that brush and that leaf litter, like I had said. So when you walk on the trail, don't veer off the trail. Stay in the center, because again, you're creating a barrier between you and where those ticks will be found. Obviously, you don't throw a picnic blanket down in the middle of tick territory. Pick a bench or something like that. Again, when any kids in the yard, you want to make sure that they stay out of those areas, any kind of play areas. You want to avoid any kind of habitat. The most important thing is frequently check for ticks. You check while you're out in tick territory, and you check when you're back home, and you check the following morning, because oftentimes what you'll see is a tick attached the following morning where you didn't see it before. It may not even been on you. Maybe it was on something that you took with you, you moved it that night, and now it's on you, okay? Or it was on a piece of clothing you threw on your bed. So you need to do frequent checks even the day after. Obviously, remove them promptly. Powassan can be transmitted within about 15 minutes, but most of the bacterial infections take approximately 24 to 36 hours. So it's very, very important to remove ticks as quickly as possible to prevent any kind of transmission from pathogens. Another good thing is anything that you wear outside, when you bring it home, put it directly in the dryer. Don't put it in the clothes washer. They survive the clothes washer. I've done experiments with hot water, Clorox, detergent, everything, and they survive. So, again, you throw it in the clothes washer, you reach in to pull it out, they're alive still. So you want to throw it right in the dryer for 10 minutes. That will desiccate even Lone Star ticks and American dog ticks, which are less susceptible to desiccation, as I said. So 10 minutes for most items will disinfect those items from any kind of live ticks. And then obviously using tick repellents, which I had mentioned. There are 5 that the CDC recommends, and the whole idea is they give you about 4 to 6 hours of protection or repellency. Permethrin is clothing only. We use it on the outfits that we use outside. It can survive 7 washings, so you can apply it when you're not wearing clothing, apply it, let it dry, it binds to the clothing and survives 7 washings. DEET is what most people use on their skin as well as repellents, and the other 3 are becoming more and more available when it comes to the products that are out there. But DEET typically, the percentage is around 30%. Any higher percentage of DEET, over 30%, is not more effective. So you don't need to buy anything over 30%. So proper tick removal, you don't use cigarettes, you don't use jet fuel, you don't use, nail polish, in a way, what they say is you don't want to annoy the tick because it can regurgitate the gut contents into the bite site. So you don't want that to happen. So the only thing you do is you reach down with a pair of fine tip forceps as close to the skin as possible and pull straight up. So the only thing that is left in this, or anything, the only thing that enters the skin is that hypostome, which is, it's a barbed mouth part that enters. It can't go past these are called palps, these 2 items. So it can't go any further than that. So it doesn't really take a whole lot. They secrete a cement that helps them adhere. So when you pull it off and it looks like it has skin, that's actually a cement that they secrete to allow them to adhere to the bite. So they're less likely to be bumped off. But oftentimes the skin will swell around the bite, and so it looks like it's buried in, but it's not. So just reach down, pull straight out. And then, even if the mouth part remains in, that will be sloughed off. It's not infectious. You can treat it topically and go on your merry way. Thank you.
Thank you, Dr. Campbell. Well, next up is one of our emergency room physicians, Dr. Max Minerop. Dr. Max Minerop attended medical school at Stony Brook University School of Medicine and completed his residency in emergency medicine at Stony Brook University Hospital, where he was also chief resident. Dr. Minerop is board certified in emergency medicine and has worked at Southampton's hospital's emergency department for the past 9 years. In addition to seeing patients in the emergency room, he serves as the medical director for the local emergency medical service agencies in East Quogue, Hampton Bays, and East Hampton, and he's also Southampton's representative to and chairman of the Suffolk County Regional Emergency Medical Advisory Committee. Dr. Max Minerop.
Thank you. Thank you. So, the very beginning of this has some slight repetition from what Scott spoke about, but the more we hear things, the more we remember them. No? Okay, let me turn the mic up a tiny bit. Okay. So, as Scott said, we have 3 types of ticks in our area. The ones we worry about the most from an infection point of view are the deer tick and the Lone Star tick. The deer tick carries anaplasma, Poisson, Lyme, and Babesia. The Lone Star tick carries ehrlichiosis. So you're going through a walk, walk down to the beach, or on a trail, wherever you like. Your deer tick or your Lone Star tick is there questing, as he said, and you're unlucky enough to have him or her grab onto you as opposed to a passing deer. The tick climbs up your body, finds an area that it finds hospitable, typically, areas like behind the knee, the waistband, the armpit on children, often the neck, the head, the ears, and it finds a little spot. It makes a tiny cut in that area, puts some anesthetic down so you don't really feel it, buries that barbed hyposome into you, and cements itself into place, for the duration. It wants to get a blood meal so it can move on to the next stage of its life. And during the process of feeding, can transmit one of these tick-borne diseases to you. As he said, somewhere typically between 24 and 72 hours, 36 hours is typically the time you worry about. It's normally after the tick is engorged. So if you're removing a tick that has no blood in it, the risk of it spreading any infection except for the potential of Poisson is extremely low at that point. So Lyme disease. Lyme disease is the disease that everyone worries about the most out here. It's the most common. It's also the hardest to initially identify. It has the most indolent initial presentation. It's, as we said, transmitted by the deer tick. So if you're bit by a Lone Star tick, you don't have to worry about Lyme disease. If you're bit by a dog tick, you don't have to worry about Lyme disease. So the reason we miss Lyme so often is the nymph tick, which is the one that spreads most of the disease. It's not the one that has the most Lyme in it if we go and sample the ticks, but because it's about the size of a poppy seed, it's very easy to miss this tick on your body. Once it fills up and it's engorged, it's closer to the size of a sesame seed, but by that time, often, unfortunately, it's transmitted disease. As Dr. Campbell said, everyone always blames the deer, and I said the deer are, you could look at them more as sort of the mobile home for deer ticks. They're not getting infected, with any of the pathogens by the deer. The deer actually have a very active immune system. They don't get sick from Lyme, but they bring the ticks to your backyard, and thus increase your exposure. It's the white-footed deer mouse that is the reservoir. We use words like vector, reservoir, host. When we speak about tick-borne disease, reservoirs are where the disease lives in the population. The vector is the tick, that's the one who transmits it to us, and the hosts are the deer or us, and what we would consider an inadvertent host. A tick would much rather bite a deer than us. I mean, deers don't have fingers. They're not going to pull the tick off within, hopefully a day of getting bit. So you get bit by this deer tick, and you pull it off. Unfortunately, it's been about 72 hours. It looks kind of like this guy over here, has some blood in it, and you end up getting inoculated with the spirochete, called Borrelia burgdorferi, that transmits Lyme disease. If you're one of the lucky ones who you're unlucky to have been bit, but you're lucky to develop a rash, the classic rash of Lyme disease is called erythema migrans. It's a bullseye-shaped rash. It comes in variable presentations, but if somewhere between 30 and 50% of people will get the classic rash after having been infected. If you notice this rash, chances are you're going to recognize it, you're going to seek treatment, and with any luck, your foray with Lyme disease will be over forever. If you're one of the ones who don't get that rash or you don't notice that rash, this is where Lyme starts to get much more complicated. Lyme disease likes the central nervous system, as Dr. Coyle will speak about more. It tends to hide, away, makes it very hard to detect. And so that initial infection, when you have this rash, you may have no other symptoms, just this rash, and I feel fine. What is this rash? Over the next week or so, you tend to get a low-grade fever. You feel a little bit sick, but often not enough to stop us in our tracks or make us go and seek medical attention. And then that's where things get worse and gets to be more interesting for me as an emergency room doctor. People start to develop facial nerve palsies where half their face doesn't work. They develop big swollen knees where the Lyme has invaded that knee and caused an arthritis of that knee or that joint. The Lyme can invade the central nervous system, cause meningitis, which is certainly an emergency and needs to be treated aggressively. And it can also affect the heart. It involves the nerves or the muscle of the heart and can affect the way we conduct electricity through the heart, putting us into what we call heart blocks typically, where the heart goes very slow and pumps ineffectively, backing fluid up into your lungs and making you very sick. For the most part, we treat Lyme with doxycycline. It's the standard treatment for Lyme disease. Somewhere between 10 days and 28 days, depending on the severity of your illness. If you have one of central nervous system Lyme disease or cardiac Lyme disease, you're going to end up being on an IV antibiotic called Rocephin or ceftriaxone, which gives much better penetration into the deep parts of our body and helps us to eliminate the Lyme. As you get into the final stages of Lyme, things get harder also, what we call chronic Lyme, which many people suffer with. Some of them had Lyme disease, some of them probably never had Lyme disease, and they blame everything on the Lyme. But it has more to do with the damage that the bacteria did, not an active infection at that point. And it's best, of course, to prevent yourself from being bitten by a tick, catch the infection early, and treat early so that you never end up in that position. Okay. So, Babesia is a much more aggressive infection. People typically aren't going to wonder if they have Babesia. Many people wonder, do they have Lyme disease? Is this Lyme? Babesia, you've been hit by a truck. It's July. We see most cases in July and August. You have a high fever, severe body aches, an awful headache. You really haven't felt this sick in a long, long time. It's as I said, a protozoan, not a bacteria. It invades your red blood cell. So just like malaria, you're bit by this tick. It feeds on you for 48 hours or so. Babesia gets into your system, and it starts to replicate. So within a week to 2 weeks, you start to get fevers, body aches, a flu-like illness, people call it, but not the classic flu where you have a cough and a sore throat. But just really no symptoms except these fevers and body aches. we will, you come to the hospital, your blood is drawn, we'll notice that you have anemia, meaning a low red blood cell count or a low blood count. This is because the Babesia has invaded the red blood cell and it replicates in the red blood cell, and then eventually there's too many of them in there and it makes the cell burst. That bursting releases all kinds of inflammatory mediators into the body, which is what makes you feel sick and gives you this relapsing fever. You're getting a little better, then all of a sudden, boom, you feel very sick again. When we look at your blood, if you have a significant amount of Babesia in it, we'll actually be able to identify it, on that visit, inside the red blood cell. Will we be able to tell that you have malaria or Babesia? No, but we will assume that if you haven't been traveling to Africa or Central America, some other malaria endemic area, that this is babesiosis, and the nickname for it is Montauk malaria, that you will get treated appropriately. So the thing about Babesia that's different than all the other tick illnesses is that it's not treated with doxycycline. We give an antibiotic called Mepron as well as an antibiotic called azithromycin. Both can be given orally, and if you are well enough, don't have a very high load of this parasite on your smear of blood, if you are not extremely dehydrated, needing other supportive care, you'll be able to go home on 2 oral antibiotics and do well and beat this illness. However, if you have more than about a 10% load, meaning when we look at your blood smear, 10% of the cells seem to have the parasite in them, you'll need to be hospitalized, sometimes even transferred to a tertiary center, and go through what we call an exchange transfusion, where they actually take a portion of your blood out to clear the infection and replace it with transfused blood. Thus, you don't have as strong of a reaction. Okay. Poisson virus, as you said, it's a very rare disease. It's getting a lot of attention because, like most viral encephalitises, which most of them we see from mosquito transmission, it can be transmitted very quickly. I mean, imagine how long a mosquito is on you to transmit a disease in comparison to how long a tick is on you. Like all viral infections, for the most part, there is no specific treatment for Poisson. It's supportive care, Tylenol, Motrin, IV fluids. Make sure you don't have a bacterial meningitis and treat you for a bacterial meningitis until we know you don't. But other than that, your body will have to beat it. I said, fortunately, we really don't have any cases of reported Poisson in Suffolk. So there's more fear out there about Poisson than there deserves to be. So Ehrlichia, which is transmitted by the Lone Star tick, is very similar to Anaplasma, which I would akin the two to each other. They infect 2 different kinds of white blood cells, but basically this bacteria, you're bitten by the tick, the bacteria is transmitted to you, it invades your white blood cell, which is what is the cell in the body that's designed to fight your infection. So the white blood cell thinks it's doing its job. It goes, eats the bacteria, high fives all around, everybody's happy, the bacteria is gone, and the bacteria starts multiplying inside the white blood cell, eventually bursting it, and then re-releasing into the bloodstream. You can get very, very sick very quickly from ehrlichiosis. We don't have any testing to tell us you definitely have Ehrlichia, immediately available to us in the emergency department, but we tend to see patterns in your blood work. We see that you have a very low white blood cell count instead of a high white blood cell count, which typically people fighting an infection do. We see that your platelet counts go down very low, and we often see that your sodium in your blood drops, as well as we see a change in your liver function test. So anytime we see those patterns, you have a fever that we can't explain some other way, we're going to presumptively treat you with doxycycline at that point. It's far better to treat than wait for someone to decline while we're waiting several days for a confirmatory blood test to come back. Okay. So the other thing about the Lone Star tick is that it can cause a reaction called alpha-gal, which Dr. McGinty will get much more into. Essentially, though, very, very superficially, it can be transmitted by any stage of the tick because it's not an infection, and it will make you then allergic to most mammalian meats. Okay. So So why come to the emergency department for a tick bite? When to do it and what should you expect? I mean, it can be as simple as you have a tick stuck on you somewhere you can't get to, and you don't have anyone else that you trust to take it off. People come in for this all the time. Many people at that point, there's sort of a practice of prophylactically treating for Lyme disease when you're bit by a tick. It's not completely recommended. Do I do it sometimes? Absolutely, if that's what the patient wants. I think there's very little harm to taking 1 dose of doxycycline when you remove a tick. But the number needed to treat, meaning how many people do you have to do this for to make a difference, is about 50. So it's an overused practice in general. And most of the ticks are not engorged with blood. They say that tick should have been on you for about 72 hours before you really need that dose of doxycycline, or would benefit in any way from that dose of doxycycline. The more acute reason to come to the ER is, I have a high fever in the summertime, and my body aches, and I don't know what's wrong. In the emergency department, you're going to get to an answer much more quickly than you would at an urgent care or your primary care's office, and get on appropriate treatment and receive the supportive care you need to beat Ehrlichia anaplasma. I mean, these are diseases with real mortality rates. People die from Ehrlichia, they die from anaplasma, they die from Babesia. Lyme, unless it really gets into your heart's conduction system and you die from that, Lyme makes you old. It doesn't kill you typically, So I would urge people, if they have a fever, to come in and be seen, in the middle of the summer, to come in and be seen. Okay. Any other questions? Or at the end, sorry. Yeah.
Thank you, Dr. Minerup. Our next presenter is Dr. Patricia Coyle. Patricia Coyle is Vice Chair and Professor of Neurology at Stony Brook University Medical Center, as well as the Director of the Stony Brook Multiple Sclerosis Comprehensive Care Center. Dr. Coyle received her MD degree from Johns Hopkins School of Medicine, where she completed a fellowship in neuroimmunology and neurovirology. She established a successful research laboratory in addition to building a busy clinical practice at the Stony Brook University Medical Center. Her areas of expertise include multiple sclerosis, neuroimmunology, and neurological infectious disease, in particular Lyme disease. She's currently involved in a number of therapeutic trials testing new immunotherapies for MS, as well as studies addressing the neurological aspects of Lyme disease. Dr. Coyle is in demand both nationally and internationally as a lecturer on MS and neurological infections. Dr. Coyle.
So it's a real pleasure for me to be here to talk about neurologic Lyme disease, which is a very hot topic. We recognize Lyme disease as the major tick-borne infection. We've heard about several, but Lyme disease is the major one. And it's important to emphasize this is a bacterial infection, which means it's eminently treatable with appropriate antibiotics. That should take care of the Lyme infection. It's not untreatable, it's very treatable. The earlier you get appropriate treatment, the better. You can get reinfected, by the way, but it's an eminently treatable infection. You want to get the appropriate antibiotics. Now, not everybody that gets inoculated with a bacterial spirochete, Borrelia burgdorferi, gets sick. So you may have somebody who's inoculated and they're able to contain the infection, or they didn't get pathologic strains. They may be Lyme antibody positive, but they don't necessarily have an active infection. We don't really know the percent of people that have asymptomatic infections with B. burgdorferi. We do know it targets specific body organs, the skin in particular, that erythema migrans, or EM. That's what most people have, and you don't need any laboratory data. Don't need any blood work. If a doctor says you have an EM, you've been diagnosed with local Lyme disease. And then it targets the joints, as we've heard about, the heart, and then the nervous system, both central and peripheral nervous system. Now, the nervous system can be involved very early on, very quickly. We think it depends on the strain of the spirochete that you get inoculated with by the tick, that there are neurotropic strains that can spread very quickly to the nervous system. Or you may see neurologic disease late. A sister spirochetal human infection is syphilis. And one of the features of spirochetal infection are stages. So once the spirochetes seed to a body organ, they may remain quiescent there for quite some time and then pop up with late disease. Only a minority do, but that's why it's so important to treat early and take care of the infection. You don't want to risk, if the infection goes untreated, of having a late neurologic infection. Important fact, most neurologic Lyme disease cases occur from May to October. Now, they can occur year-round, but highly unusual outside of that window. And there are characteristic neurologic syndromes of Lyme disease, and that's a key factor. So first of all, this peripheral facial nerve palsy, or cranial nerve 7, where one side of the face gets paralyzed. You can't close your eyelid very well. You may not be able to close it at all. You can't wrinkle your forehead, and one side of the face is drooping, almost like you have a stroke, but a stroke doesn't involve the forehead. One key feature that would confirm that unilateral facial weakness is likely a facial nerve palsy is there any tearing abnormality, increased or decreased? You don't see that with a central issue. Is there a hearing, hyperacusis, abnormal hearing on the side of the weak face? And is there loss of taste on that side of the tongue? Tearing, hearing, taste abnormalities associated with a unilateral facial weakness would be would really say this is a peripheral cranial nerve 7 facial nerve palsy. Now, we also call it Bell's palsy, but actually it's not. By definition, Bell's palsy, which is a cranial nerve 7 peripheral facial nerve palsy, is an idiopathic facial nerve palsy. You couldn't find a cause. If you know it's Lyme disease producing the facial nerve palsy, it's actually not Bell's then. It's a Lyme-related facial nerve palsy. Most idiopathic Bell's palsies are due to herpes simplex or varicella zoster. They're due to herpes viral infections, and that's the basis of giving an antiviral agent. But of course, if Lyme disease is doing it, that's not a virus, that's a bacterial infection. One big hint is the facial paralysis accompanied by a multi-symptom complex. Like, in addition to the face getting weak, looking like it's an acute stroke, but your arm and leg are fine, that's not an issue. Does the person have joint pains, muscle pains, headache, stiff neck, fatigue? That multi-symptom complex, along with the facial nerve palsy, would be highly suggestive for neurologic Lyme disease. And it's said that up to 25% of facial nerve palsies on Long Island in summertime are due to neurologic Lyme disease. Another characteristic syndrome called acute painful radiculoneuritis. No headache, no stiff neck, but spine pain. Terrible spine pain coming out of the blue. And then you may have problems with numbness or weakness of hands or arms, but it's in a strip, almost going back to a spinal nerve root type issue. No headache, no stiff neck, but bad spine pain, maybe in between the shoulder blades, and then you're having some sensory and motor abnormalities. That's a very characteristic syndrome of early disseminated neurologic Lyme disease. And then the meningitis. What does meningitis do? Meningitis is inflammation of the lining membranes of the brain. So you get a bad headache, but it's accompanied by a stiff neck. How would you check for that? Put your chin to your chest. You're stretching the meninges, which are inflamed, so that hurts. So that's the sign of a meningitis. But Lyme meningitis doesn't act like a regular bacteria. Bacterial meningitis is life-threatening, and people get sicker and sicker, and they'll die often if you don't get appropriate antibiotics. For a viral or so-called aseptic meningitis, that's not true. It's a paler picture of a meningitis. Yes, you get bad headache and stiff neck, but you're not looking at the patient and saying, oh, they look horrible, we've got to admit them to the hospital. They don't look that bad. and they'll spontaneously get better after a couple of weeks. And there are a lot of viruses that can cause meningitis, and there's no specific treatment, and ultimately they do well. Well, Lyme meningitis mimics the viral picture, not the bacterial picture. So if somebody has bad headache and stiff neck, doesn't look too sick, but bad headache and stiff neck out of the blue in the summertime, that could be Lyme meningitis. They need to be evaluated. They need to be worked up for that. Then you have a neurologic syndrome, the most common that we see later on due to Lyme disease. And it's a little bit vague and elusive. It's called late Lyme encephalopathy. This isn't talking about people that suddenly get demented. This isn't talking about people that suddenly have a huge lapse in their memory and cognitive abilities. It's much milder, much more subtle. They're typically still able to operate, still able to go to work, etc., but they know they're just not thinking right. They know they're just not as sharp. They know their mind, their brain is just not working properly. So it's a subtle issue. That can represent late neurologic Lyme disease, anywhere from 3 months or longer after the initial inoculation with Borrelia burgdorferi. And then an age-related neurologic syndrome in children and adolescents, teenagers, the intracranial hypertension syndrome. A child or adolescent who presents out of the blue with headache during summertime in a Lyme endemic area, you would never ignore that, but they need to be neurologically evaluated. If their headache is associated with papilledema, when somebody looks in the back of the eye with a fundus exam, they may have a neurologic Lyme disease syndrome, and that needs to be recognized and worked up. So you want to make sure that a child or adolescent with new headache gets an evaluation, including looking at the back of the eye to make sure it doesn't look like they have what we call a choke disc or papilledema. You will only see that if you look in the back of the eye with a fundus examination. All right, so what's the workup? What's the diagnostic workup for suspected neurologic Lyme disease? Well, the first thing you want to say is most should absolutely be Lyme antibody positive. In their blood, they should have evidence that they've mounted an immune response against the invading bacteria, Borrelia burgdorferi. And our typical antibody test is a two-tier system. We do a screening test, typically what's called an ELISA, but then it must be confirmed by a second test called a Western blot or an immunoblot, which is more time-consuming, more expensive, and requires a qualitative read. That's currently the state of the art. The screening ELISA has a built-in 20 to 25% false positive rate for a bunch of reasons. But it'll typically be a low false positive. And then you go to the Western blot and it's not confirmed. There is a recombinant protein-based test called Lyme C6 peptide, okay? But I think this is going to be revolutionized in the next few years. And we're going to drop the Western blot, I think, and we're going to drop the typical ELISA that does a sonicate of the whole gamish. And what we're going to be going to, I think, in the next few years are maybe 2 recombinant-based tests, or maybe one big one based on multiple very purified antigens. We're going to get better about that. I think that's going to change. Can you be antibody negative and have neurologic Lyme disease or have Lyme disease? It's possible. We believe it's very unusual. What would stop somebody from making antibodies? Early abortive antibiotics. After you get inoculated with the spirochete by the tick, it does take a couple of weeks for your immune system to make antibodies. It starts coming up at about 2 weeks, 3 weeks. The IgM Western blot is the first one positive. If you took any form of antibiotics, like somebody thought you had a strep throat, and they gave you antibiotics for that, early on, you can abort the antibody response, and you might create an antibody negative, what we call seronegative case. So the vast majority of Lyme disease cases, neurologic Lyme disease, are going to be antibody positive. They're going to be seropositive. But occasionally it can happen if they got early abortive antibiotics that can interfere with that. And then another test that I might often do if I suspected Lyme disease is I might check for antibodies to Babesia and that human granulocytic anaplasmosis, because it's going to bolster the right tick exposure. So I might do that in the blood. But the major test you want to do if you suspect neurologic Lyme disease is a lumbar puncture and take off cerebrospinal fluid, CSF, which is the blood of the brain and the spinal cord. And we are underdoing this test. In my opinion, this is a required diagnostic test for anybody where you are raising the possibility they could have neurologic Lyme disease. It would be typical to look at their spinal fluid and evaluate it for Lyme antibodies, and in particular, intrathecal Lyme antibodies. What does that mean? Higher antibody titer against the Lyme agent in the spinal fluid than in the blood, because you can get little leakage in. I'd also be looking for increased cell count. The normal cell count in spinal fluid is 0 to 5 white cells per millimeter cubed. I might see 20, 30, 100, 200 if somebody had a meningitis or an inflammatory infection. And I'd also expect the total protein in the spinal fluid to be up. Plus, you can rule out other conditions. Just think of the spinal fluid as the blood of the brain and the spinal cord. So if you suspect a neurologic infection, you almost always want to look at spinal fluid. Imaging of the brain is typically not helpful because the vast majority of neurologic Lyme patients will have normal brain MRIs. Now, I might do it. I might want to do it, but I don't typically expect it to be abnormal. Only about 20% will have lesions there, and some of them may disappear after appropriate antibiotic treatment. There's a nuclear medicine test called a brain SPECT that's sometimes done. There is no typical brain SPECT for neurologic Lyme disease. If somebody says that, they really don't know what they're talking about, okay? And then other tests, you may want to do cognitive function testing. If I suspect somebody with late Lyme encephalopathy, I would probably want to do that before they got antibiotic treatment and then months after to show improvement. And electrophysiologic testing, meaning nerve conduction tests, EMG, if I suspected peripheral nervous system involvement with Lyme disease. How do you treat it? Antibiotics. You want to give appropriate, this is a bacterial infection, nothing magic. The right antibiotic should get rid of the Lyme agent. But if you have nervous system involvement, the CNS, which is relatively sequestered, the oral antibiotics that we typically use don't penetrate very well. There have been clear cases of neurologic infection after doxycycline courses. Doxycycline does not penetrate that well. So if I feel the patient has neurologic Lyme disease involving their central nervous system, a relatively sequestered key body organ, I'm going to give intravenous antibiotics, ceftriaxone, 2 grams once a day, run in over 30 minutes, and I'm personally going to use it for 28 days, for 4 weeks. Now, all the guidelines talk about treating for 2 weeks to 4 weeks. And if we're being very honest, evidence-based, there's a New England Journal article from some years ago that looked at neurologic Lyme disease, giving IV ceftriaxone 2 weeks and 4 weeks, and the results were the same, exactly the same. So you would say, well, why are you giving 4 weeks if the article said 2 weeks was as good? And this is a personal thing. Early on at Stony Brook, we had several patients with neurologic Lyme disease that lapsed after 3 weeks of IV ceftriaxone. They relapsed. We had to retreat them. When we went to 4 weeks, we didn't see anybody relapsing anymore. So we've kind of kept to that. I'm telling you very honestly, even though there's that New England Journal. And I'm hoping we get a better active infection assay to guide me better. But I'd rather maybe over-treat early and take care of the problem than have the patient coming back later. That's the attitude that we've taken. There's also in the literature an article saying doxycycline works for neurologic Lyme disease. That's from Europe, not from the US, not from North America. And there are differences between the Lyme spirochetes in Europe versus the US. And there have clearly been neurologic cases after doxycycline, so we do not like to use that. We will typically talk about putting in a line that can be used for 28 days. We put patients on daily acidophilus because pseudomembranous colitis can rarely occur. We alert them with the line if it got red or it hurt, that's abnormal. It could get clotted or infected. Doesn't happen very often at all. But these are the things we tell people about. And then I've never seen a case of this, but ceftriaxone is excreted in biliary sludge. And years ago, there were some examples of gallbladder disease, right upper quadrant. So those are the three things that we counsel patients about. But it's very rare to have complications. So to summarize, I think it's important that everybody here recognize the symptoms of neurologic Lyme disease in summer, because you're all at risk. We're all at risk living in a Lyme endemic area. If you have a clearly neurologic issue, best to see a neurologist. Okay, because there's a differential diagnosis. It may be neurologic Lyme disease, it may be something else. Absolutely have an appropriate workup, and that, for all intents and purposes, must include evaluation of spinal fluid, in my opinion, and then get treated, and intravenous antibiotics for documented or highly suspected neurologic disease, I think are really the best way to go based on the best penetration. Thank you.
Thank you, Dr. Coyle. Dr. Erin McGinty is, we refer to her as our alpha gal, and she'll explain that in a little bit. Dr. Erin McGinty obtained her medical degree from SUNY Stony Brook and her training in pediatrics at the Children's Hospital of Philadelphia. Following her residency, Dr. McGinty pursued subspecialty training during a 3-year fellowship in allergy and immunology, with adult cross-training at the Hospital of the University of Pennsylvania. She's board certified in allergy and immunology, and in 2009, she returned to New York and joined ENT and Allergy Associates, where she practices both adult and pediatric allergy and clinical immunology. With a special interest in meat allergy, alpha-gal, which is caused by the Lone Star tick, Dr. McGinty has presented nationally on the subject and has been interviewed about alpha-gal by a number of media outlets, including the Associated Press, Sirius XM Satellite Radio, and the BBC. Dr. McGinty sees patients at her office in Southampton. Dr. McGinty.
Good morning. Morning still. Yeah, I'm going to switch gears a little bit from all this talk about tick-borne diseases, and I'm going to talk about a food allergy that is caused by tick bites. And normally I talk about this allergy in a talk that takes about an hour, so it was a little bit of a challenge to kind of pare this talk down, so bear with me. So just to start, what is alpha-gal? So alpha-gal is a nickname for galactose alpha-1,3 galactose, which is a blood group carbohydrate that is expressed in all non-primate mammals. And it's expressed widely throughout all the cells. So non-primate mammals, I'm basically talking about cows, pigs, deer, guinea pigs, cats, dogs. Pets can't become allergic to alpha-gal because they are non-primate mammals. It's part of their genetic makeup. Humans, apes, monkeys, we don't express alpha-gal due to an inactive gene product. And that's why we can become allergic to it. So there's a really long and interesting story about how alpha-gal allergy was first developed. And it actually, the tick link was not made until later. It was actually first discovered in the context of a chemotherapy drug which was a monoclonal antibody that was developed in a mouse cell line, and the drug actually had alpha-gal in the finished product, and they were seeing patients in certain portions of the country who were having anaphylactic reactions with their first exposure to the drug, suggesting that they had some preformed antibody present that was setting them up for that reaction. Within that study, there was a small subset of the patients who had reacted to the cetuximab, which was the drug, who were also reporting that they felt like they were allergic to meat. And so that intrigued some of my colleagues down at University of Virginia. And in 2009 was when the first paper on alpha-gal, the meat allergy, was published, and this was published in the Journal of Allergy and Clinical Immunology. And my colleagues down at UVA reported on 24 patients in the Southeast, which is where this drug was first discovered. And these patients in their study were demonstrating onset of allergic reactions that were occurring 3 to 6 hours after ingestion of meat from a mammal. They often did not have positive skin testing, which is sort of the gold standard for diagnosing most food allergies, unless it was injected under the skin. And this was just a breakdown of their patients. And the important points I just want to point out are they were able to demonstrate in these 24 patients that all of them had measurable antibody to alpha-gal, ranging widely from as low as 0.52, negative is considered anything less than 0.35, all the way up to greater than 100. And yet all of them were clinically reactive, and they all reported a delay in the onset of their symptoms. This is hours, so ranging anywhere from 3 to 6 hours after they ate the meat, which is very atypical for a food allergy. So what kind of reactions do we see? Alpha-gal does not cause chronic symptoms. Alpha-gal does not cause a chronic skin rash. Alpha-gal does not cause chronic abdominal pain. If you're allergic to alpha-gal, your allergic reactions are going to look very similar to an allergic reaction that someone might have to a bee sting or that someone might have to a peanut. These are acute allergic reactions, just like every other allergic reaction I treat. The difference is this delay. Okay, most allergic reactions happen immediately. Alpha-gal reactions typically occur as 3 to 8 hours later. And for that reason, I do a longer talk, and I call it midnight anaphylaxis, because the vast majority of cases will present in the middle of the night. So in my office, anyone who comes in complaining of waking up in the middle of the night having an allergic reaction, my next question is, what did you eat for dinner that night? What kind of symptoms do we see? Hives, itching, that's by far the most common symptom. So 80 to 90% of people who have an alpha-gal reaction are going to present with itching and hives. Often people will complain of abdominal pain, and these symptoms can be severe and quite common in alpha-gal allergy. Up to 50 to 60% of patients will present with abdominal symptoms, nausea, vomiting, diarrhea, severe cramping. People can become lightheaded and occasionally pass out, and that's due to a drop in blood pressure. And I do see this occasionally in patients with alpha-gal allergy. And then less commonly, we will see people who have difficulty breathing, chest tightness, and full-blown multi-organ system involvement, which we refer to in the allergy world as anaphylaxis. That does occur with this allergy. It's not the typical presentation, but we do see it. So it's not like everyone who has alpha-gal allergy is going to go into anaphylactic shock when they eat a bite of a burger, but we do see it. Oops. So why do we think there is this delay? It appears to have something to do with the fat in the meat, okay? So alpha-gal itself is a carbohydrate, but there's something to do with the fat, because we do know that the fattier the meat, the more likely someone is to have an allergic reaction, and the more severe that reaction is likely to be. without getting into it, fat, when we eat something with fat, it takes about 3 to 4 hours for the fat to be absorbed into our bloodstream, and that's kind of when we see the reactions of alpha-gal. So that's why we believe there is this unusual delay of hours before the allergic reaction occurs. Patients do not feel symptoms when they eat meat. It's not like a peanut allergy where they put the peanut in their mouth and their mouth starts to get itchy. If you put meat in your mouth and your mouth starts to get itchy right away, I don't know what that is, but my first thought is this is not alpha-gal allergy, because that's just not the way this allergy works. And here's actually one example of an actual meat challenge, and hopefully it's projecting well, but this is a patient who has positive alpha-gal IgE testing. This was her before the meat challenge. And for meat challenges, we'll typically feed a patient 2 sausage patties from McDonald's. That's just sort of by convention. Patients need to be observed for at least 8 hours when we do a meat challenge, so not too many people are enthused about eating a burger at 7:30 or 8 in the morning. So we went with a high-fat breakfast meat. So we do sausage patties, and here she is, and this is almost 4 hours after eating the meat, and I don't know if you can see her palms are very red. She's getting blotchy here on her arms. And I have a bunch of other slides of challenge reactions, but in the interest of time, I left those out. So a food allergy caused by a tick bite is a very novel concept. And the link to the ticks actually came several years after the allergy was identified. But there were some suspicions that this could have been an issue dating back as early as 1989 when a woman by the name of Sandra Latimer, she's a layperson living in Georgia, rural Georgia, and she went to her local allergist and said, I know about 11 people who have gotten tick bites and now they're allergic to meat. So it never actually went anywhere there, but there is a letter written to the Georgia State Allergy Society by this woman and her local allergist reporting this suspicion dating back into the late 80s. So knowing about that, my colleagues down south started thinking that maybe that is the reason why we're seeing so many more issues with alpha-gal allergy, initially in the southeast, which is where they thought it was the only place that it affected. So this is a map back from 2011, and this was from the paper I mentioned earlier, showing the states with the large stars are the states with the largest number of alpha-gal cases reported. And you can see, sort of striking, if you see, this is a map just looking at the geographical incidence of Rocky Mountain spotted fever. You can see the states that are most affected are sort of in the same area. So tick endemic areas, it seems that places that are heavily populated with ticks and tick-borne diseases also saw more cases of alpha-gal allergy. And this is a dated map as well. I haven't seen an updated one, but this is the geographical distribution of the Lone Star tick according to the CDC website from 2012. So you can see some parallels. And what the guys did, once they suspected this tick theory, they looked at it in a couple of different ways. This is a graph showing alpha-gal antibody on this y-axis and total allergy antibody on this axis. And the people in the red triangles are the people who specifically reported having experienced tick or chigger bites. And as you can see, the people with the red triangles tended to have the higher titers of alpha-gal antibody. So clearly just an association, but worth noting. This is a table looking at IgE to alpha-gal allergen on the bottom axis and IgE to other Lone Star tick proteins. And you can see the patients who are higher in alpha-gal antibody also were higher in antibodies against other tick proteins. So again, another correlation, not clear proof. The most compelling story was when they actually took 3 patients from the control group who during the course of the study reported that they had sustained multiple Lone Star tick bites. And in each of these 3 patients, The bottom line is the most important line. That's actually IgE antibody to alpha-gal, allergy antibody against alpha-gal. They were all negative, and then the red arrows are when they actually sustained Lone Star tick bites. And you can see in each of the patients after Lone Star tick bites, their alpha-gal antibody went from negative to positive. This one went only slightly. The other two went more significantly. And then it would trend down, and then if they got another Lone Star tick bite, it would start to trend up again. And the red stars are actually incidents of allergic reactions to meat in patients who were originally in the control group who had never had a problem with meat before. Those are my most sciencey slides. Now I'm just going to talk a little bit more practically. So my own personal experience with alpha-gal, I diagnosed my first case in end of 2011, and at this point I'm pushing 400. At this time of the year, it's hard to give a definite number because I'm seeing new cases every day. When I spoke to the guys down doing the research on this allergy, my cases were the first identified on Long Island. So how do I make the diagnosis? When do I suspect alpha-gal allergy? So first of all, patients are almost invariably going to give a history of having had Lone Star tick bites. And realistically, it's usually going to be relatively temporally close to when they had their first reaction. It's unusual for someone to present in February, and I understand Dr. Campbell said people can get tick bites at any time of year, but you also saw when he said Lone Star ticks were active. It would be very unusual for someone to present with their first alpha-gal reaction in the middle of the winter. People are much more likely to have their first reaction in the weeks to a month following a Lone Star tick bite. So not only do I usually get a history of Lone Star tick bites, I can usually get a relatively recent history of a patient having had a bite within the month preceding the reaction. Just because a patient tells me that they can sometimes eat meat does not rule out this allergy. Again, it's very different than other food allergies. There are some patients who are exquisitely sensitive and can't even eat a piece of chicken that was cooked on a grill that cooked meat. That is definitely the exception rather than the rule. It happens, but that's not the typical story. More typically is someone who had a reaction after they ate a burger at, a restaurant, but then didn't realize what it was, and a few days later ate a roast beef sandwich from the deli and they were fine. Again, it all comes back to the fat content. So just because someone's sometimes eating meat does not mean that they couldn't have this allergy. You may hear, there's a alpha-gal patient blog that you can find on Facebook. If you do internet searches, you're going to find all sorts of things. And many of my patients ask me, am I allowed to consume dairy? Or they self-diagnosed and they haven't been eating dairy for years. Again, minority of patients can have problems with dairy. It's typically higher fat dairy like ice cream, but the vast majority of patients, even patients who have had anaphylaxis to a burger, typically are able to tolerate dairy. So I do not routinely counsel people that they must avoid it. I do caution them, particularly about higher fat dairy. Gelatin, on the other hand, which is derived from beef and pork, I have seen as more of an issue. So again, it doesn't mean that if you have alpha-gal allergy, you absolutely can't eat it, but I've definitely seen patients react to gelatin. This is a super practical point, and I like to mention this just to make people aware. When I say unpublished data, I'm talking about my data, but I have a lot of patients, so I think I can make this fair comment here. Patients can have a positive alpha-gal IgE test and not be allergic to alpha-gal, not be clinically reactive to meat. Okay? The same way that a patient can have a positive peanut allergy test and not be allergic to peanut. I see so many patients who come in, their pediatrician sent a peanut test, and they come to me with a positive test, and I say, well, what are your symptoms with peanut? And they say, oh no, my kid eats peanut butter and jelly for lunch every day, but they have a positive test. A positive test doesn't make a food allergy diagnosis. It's only one piece of the puzzle, and the same goes for alpha-gal allergy. So for this reason, and I know this is going to sound scary, and I'm happy to talk to you more about it, I would discourage you from running to your doctor asking for an alpha-gal test just because you got a Lone Star tick bite. The majority of people who get Lone Star tick bites do not become allergic to alpha-gal. And in the weeks following a Lone Star tick bite is when you're at your highest likelihood of having a low positive test that may not be clinically relevant. And how much more do I have? Oh, right. And I'll just tell you really quickly, because it would probably come up in the questions and answers anyway. So then what do? You had a Lone Star tick bite, you're terrified, you're afraid to eat meat, and you know everybody's different, but there's no right answer here, but I can tell you what I do personally, because I grew up in East Hampton, and I live there now, and I live in the woods, and we get tick bites in our house. We're careful. We do our spraying, and we put our permethrin on our clothing, but we get tick bites. I just back off on the meat for a little while. I won't say I strictly avoid it, but I don't go out for a burger a week after I got a Lone Star tick bite. People are most likely to react in the couple of weeks following a bite. And then, as you saw from that slide, the antibody levels come down. So if you're nervous about alpha-gal allergy, become not a vegetarian. You can eat your chicken and your turkey and your fish. Don't eat mammal meat for a couple of weeks. And then add it back gradually. Start with lean meat. Highly unlikely, and I know there are some exceptions, highly unlikely that you're going to go into anaphylactic shock from a small piece of lean meat, even if you do have alpha-gal allergy. And that's how I approach it. That's how I approach it with my kids. That's how I encourage my patients to approach it. If someone's really terrified, I still would not recommend testing right away. If you're very scared to eat meat, I would say then avoid it for a couple of months, assume you maybe have it, and then do the test when you're less likely to get a false positive. But we can talk more about that if you have further questions. If you're going to ask your primary to send the test, which I would discourage unless they have a really good understanding of an appropriate reason to send it, they need to send it along with a total allergy antibody level, because it's not just the level that matters, it's the ratio between the two. So in summary, alpha-gal allergy causes delayed allergic reactions to meat from mammals. We know it's induced by bites from the Lone Star tick. We know it goes away over time, okay, if you can avoid further Lone Star ticks. But if you get further Lone Star ticks, the allergy can worsen. And then again, just to reinforce, not everyone who gets bitten by the Lone Star tick will develop this allergy, and false positive tests are not uncommon. Thank you.
Thank you, Dr. McGinty. Is anybody else's skin crawling at this point every time I watch one of these? Our next presenter, and we just have two more, and then we'll have some questions and answers, and thank you all for your attentiveness, is Anne-Marie Wellens. Anne-Marie Wellens, Dr. Anne-Marie Wellens is earned her BSN degree from the College of Mount St. Vincent, followed by her graduate degree in nursing education from Teachers College at Columbia University, and her Doctor of Nurse Practice at Stony Brook University. She also completed an MS degree in adult health at Stony Brook University. Dr. Wellens has worked in primary care since 2012 as part of Southampton Hospital's Meeting House Lane medical practice, and in 2015 she joined the faculty at Stony Brook University in the Advanced Graduate Nursing Education program, where she continues to teach. She's currently a member of the medical advisory panel of the Tickborne Disease Resource Center, and she's the panel's co-investigator in a Rutgers University NIH-funded study on Lyme disease, which has as its goal to develop an accurate blood test to diagnose early Lyme disease. Dr. Wellens.
So I'm going to talk about a Lyme disease study. What was alluded to earlier by Dr. Coyle is how difficult it is to diagnose early Lyme disease. So the current study that I'm involved with is, I'm actually the principal investigator, and it's basically recruiting patients that present with a rash, a typical bullseye rash, or even an atypical rash related to possible tick-borne disease. The aim of the study that we're trying to do is we're looking at collecting blood and tissue samples so that they can be analyzed to look at the immunological and inflammatory processes of Lyme disease. Very complex. The spirochete, the Borrelia burgdorferi, are a little bit different. There's different genetic, genomic makeups of these organisms. They have proteins in their cell wall, and some of those proteins are more pathogenic. So that we're trying to find the more pathogenic strains of the organism. So this is part of what we're doing with this study. We're also looking at, again, the dissemination of disease. It starts in the skin. Some organisms, some strains of this spirochete stay just in the skin, or they'll disseminate. So we're trying to look at why that's happening as well. And then the testing is really to look at, because there really isn't, if you have like a strep or a staph infection, you can easily do a culture and find it. With Lyme disease, this spirochete infection doesn't stay in the blood very long, so it's very difficult to test it, to culture it. And then the goal, again, is to look at really developing an early, accurate test for Lyme disease. So the background is tests that can help diagnose a disease, such as Lyme disease, is definitely needed. A good test, if we have a good test, particularly for patients that don't present typically. If we have a patient that comes in, if I have a patient that comes into practice and they have a bullseye rash, I'm like, slam dunk, that's great, you're going on antibiotics. Please take the whole course of antibiotics, and then you should be fine. There are exceptions, but if patients are treated early with the appropriate antibiotics for the full course of treatment, then there should be no sequelae or any chronic or complications later on. But that doesn't always happen, because what we're seeing is we're seeing more patients without a rash, presenting with elusive and sometimes vague symptoms. We're not always sure what it is. When we do the regular two-tier ELISA Western blot that Dr. Coyle talked about, if it's early Lyme, it's not going to, you're not mounting an antibody response in the beginning. It's going to take a month for those antibodies to mount, and we're not going to wait a month. We want to treat you, and if you're treated with antibiotics early, you shouldn't mount any antibodies at all. But what do we do in the beginning? How do we know? We really don't know. There is one test, which I'll talk about, which is a PCR, but that is also a problem because you have to catch it at a very specific time in order for the test to be positive. So we're in the danger months. You can see this was alluded to earlier, where like right now, the nymphs, which are the smaller of the ticks that are not easily recognized, we're exposed to during late June all the way through this time of year into August. So those are the individuals don't even know they got bit by a tick. So when patients come in and you're doing a history, you'll ask them often, were you bitten by a tick? And they'll say no. Well, they probably were, they just didn't know it. So just being in an endemic area like in Suffolk County, we're exposed, even if we don't recall ever getting bit by a tick, because you can get bit by a small nymph. It's so tiny, it feeds, it's in an area behind the knee or in the back that you just don't see, and then it falls off. And if you don't develop a rash, or if you do develop a rash and you don't know you have a rash, because not everybody looks at every single part of their body every single day, so a lot of times rashes are not appreciated. For example, I had a patient last year who came in with flu-like symptoms. high fever and, suspected in the summer. If you have flu-like symptoms in the summer, you have to think a tick-borne disease. Asked him, do you have a rash? He goes, no, I don't have a rash, but I have a sunburn. He thought he loaded up with sunblock at the beach, and he thought he missed a spot, and it was an EM rash in his groin area. So he did have a rash. So a lot of people don't even realize that they have rashes. The other problem with rashes is in African American or darker skinned individuals, you're not going to appreciate it. It's very difficult to see that typical EM or that bullseye rash. So that's a challenge, but right now we're in active season. So this is the typical bullseye rash that I was talking about. You can see that the center, the bullseye clearing around it, and then the expanding red ring around that. That's classic. We don't always see the classic rashes like this, but this is very typical. And this helps us as clinicians because we know what we're dealing with. We know that you have to be treated. Even if you are feeling well. I have so many patients that if they do have a rash, I start them on doxycycline, but I'm feeling fine. I don't have a fever. Why do I have to take this antibiotic? Well, we don't want you to get the fever because if you don't do something, if you don't start therapy, we don't want you to have symptoms or get really ill. We want to treat you even if you're feeling well, and you have to do the full course of antibiotics. So this is the two-tier test for Lyme disease. You have the ELISA, which is the first part, and again, this is not really accurate until a month out, but if you've been treated, this most likely will be negative. But at 30 days, or sometimes they call this a convalescent serum, it's the first test will look for antibodies. If it's positive or equivocal, then it'll go to the Western blot, which looks at the specific antibodies and the specific proteins. So again, this two-tier test is most commonly used when checking for Lyme disease. Again, the ELISA and the Western blot, these detect antibodies that are triggered by infection with the spirochete Borrelia burgdorferi. Okay, again, it's not an early test. So in cases like I alluded to, symptoms for less or equal to 30 days, it's usually not done, but maybe sometimes we'll do it. Depending on the situation or the case, we'll do it 30 days later. And again, we're looking for these antibodies. We're looking for IgM and IgG. Also IgA as well, but IgM, if you think of, those are antibodies. M, I always remember it by M for miserable, sick now. G for gone, past infections. This is the easy way to remember it. Okay, so with the Western blot, I have a little positives. What does it all mean? It can be very confusing. So this is the Western blot. This is the second part of the test, and again, not an early test, but it looks at the bands, which are the proteins in the cell wall of the Borrelia burgdorferi. And what they did in the studies that they've done is they've taken the organism that causes disease, and they look at these proteins. And there are some of these proteins that are in more virulent forms of the spirochete. So there are specific for the actual Borrelia burgdorferi. So we look at the bands, we look at the numbers, and usually when we send this test out, this analysis is done for us. So when I get a report back, I can look at the bands and then look at the numbers and see which is the most specific for the Borrelia burgdorferi. But usually the interpretation is done by the laboratory, which is very helpful because they do this all the time and they're expert at it. This is a PCR. I was talking about another test. It's polymerase chain reaction. This is an amplification test. And again, I am a clinical person. I am not a biologist. I do not sit at a bench with a microscope. So this is not my true area of expertise. I am really good at looking at a rash and doing a skin biopsy and drawing blood and being the researcher, the clinical researcher. But this is all, I'm collecting everything so at the back end, at the laboratory, they can figure all this stuff out. But this PCR, which has been around for a while, it's gotten much better because in the old days, a PCR to look for an organism or DNA took like weeks and weeks, but now we can do it in hours, so that's pretty good. But again, for the Borrelia burgdorferi, because it doesn't stay in the blood very long, it's like finding a needle in a haystack. If you happen to do this test at the right time where the organism happens to be sitting in the blood for that short period of time, you'll capture it. Otherwise, this test is really not very useful. Now, the PCR that I talked about amplifies sections of DNA and RNA, which are in the organism. They're specific for the bacteria. And this organism, the Borrelia burgdorferi, the bacteria, the spirochete that causes Lyme disease, concentrates in the collagen-rich connective tissue, so it doesn't stay in the blood. These spirochetes disseminate from sites of an infected tick bite via the blood, so it's transported by the blood, but the time that it's in the blood, again, like I said, is very short, very brief. And also, the spirochete load in the blood is also very, very small. So we talked about the PCR, which in the blood are fewer than half the patients in early acute stage of Lyme disease with the bullseye rash. So it's really not a good test. And by the time the symptoms of Lyme disease have been present for a month or more, the spirochetes are not in the blood. And then we can at least do an antibody test. So search for an early test. The study that I'm involved with, we're looking at something called isothermal amplification. And believe me, again, I don't sit at a bench under a microscope. But it's basically looking at parts of the Borrelia burgdorferi, the nucleic acid, amplifying that. It's like that PCR that I talked about, where it's hard to find pieces of the DNA or the RNA. This is like PCR on steroids. It's like taking PCR, amplifying exponentially. So anyway, the advantage is that this specific technique is extremely fast and it's easy because you don't need temperature changes, and that's like a laboratory thing, so it's easier in the lab to do. So the criteria for my study is that you have to be 18 years of age or older. I had to put in 110 pounds because I just got my investigational review board approval, and they made me put that in. Rash of early Lyme, and it has to be a rash. It can't be a local irritation. So it's not like, a welt. It has to be, more than a few inches. Antibiotic treatment can be started. I can recruit patients who've been on antibiotics for less than 48 hours. That's not a problem. They can't have had Lyme disease for a while. They can't come to me with chronic Lyme disease. It has to be like an early manifestation of Lyme disease. We exclude patients that have HIV or hepatitis, or if they have active cancer. The patients need to understand the consent. Right now, they have to be English speaking, they have to be able to read, and they have to be able to understand the purpose and the risks of the study, and also the benefits. So we do if I have a patient that presents with a rash, and again, they have to have the rash, and they're interested in being in the study, I have to go through the consent, 10 pages long. And I do a questionnaire. I can take a picture of the rash, and then I do a very tiny biopsy of the rash. It's 2 millimeters, we were, we just redid the consent. We were trying to figure out how, in layman's term, can we describe 2 millimeters. It's really small. It's because the other consent had about a size of a pencil eraser, and that's really big, but this is so tiny. It's actually the width of a nickel we came up with. It's actually, that's how tiny it is. So, and also there's a blood draw, and then a follow-up blood draw in 3 to 6 weeks. Now, this, all of the information with a research study is that anybody that participates, the blood and tissue samples are de-identified, so your name is not on it. You're given a number or a code, to protect confidentiality. Now, the great thing about this study is, yes, I'm involved in a study looking for an early test, but with the consent, we're getting permission from patients to share samples. So my samples from last summer went to Stony Brook because Stony Brook is looking at, again, blood testing as well. So these are my samples that I had to very carefully secure. I think this was in February or January. I used IKEA food trays and packed everything up. They had to go on dry ice. It was a big kind of, thing. And it went to California because that's where the lab did the thermal amplification study. So these are my samples that went out over the winter. And then this is in Stony Brook. This is Dr. Bruno. He's probably going to be upset if he knows that even part of his face is on a photograph. But this is the 14th floor of the towers. When you see Stony Brook, you see those towers. Those are, lots of research is going on in there. It's pretty amazing. I mean, they're doing everything. There's like all these scientists running around and whatever. But Dr. Bruno is looking at, when I was talking about that 2-tier test, he's doing an expanded protein, that lipoprotein in the spirochete. He's identifying new proteins. So my blood samples that I collected all last summer, we were able to give him part of that to also include in his study. Because identifying more proteins, particularly if they're more stronger versions of Lyme disease, is very important as well. Because if we can identify strains that are more pathogenic, then that helps us treat patients as well and understand the disease and how to manage it. And that's it. So thank you very much.
Thank you, Dr. Wellens. And our final speaker, we always ask for some real practical advice, and we found nobody better to do that than Jerry Simons. Jerry Simons is a physician assistant. He graduated from SUNY Stony Brook's Health Science Center with a degree in cardiorespiratory sciences and went on to graduate from Cornell University Medical College Physician Assistant Program. He is nationally certified as a physician assistant with commendation in both primary care and surgery. Jerry is an instructor at several major universities, including Weill Cornell Medical College. He's an award-winning international lecturer, has developed educational programs used by physicians, and is a published author on Lyme disease and tick-borne disease. In 2010, he won the national award from the Tick-Borne Disease Alliance. He practices at East Hampton Family Medicine as well as the Morrison Center in New York City. Dr. Simons.
Thanks. So I'm going to move around a little bit because I brought my supplies for you guys to look at. But I know most of you have been sitting all day, so usually I ask you to take a survey by raising your hand. But instead, I'm going to ask for anybody who's had a tick bite in the last 2 weeks, just stand up for us. Let's see some Okay. Stay standing if you've had more than 2 ticks on you. And what about 3 ticks on you? And who's on doxycycline or an antibiotic right now? Okay. And if anybody just wants to stand up for a minute to circulate, you could do that too. Also, I want to take a minute, if you see the guy in the yellow shirt in the back, Brian Kelly from East End Tick, he's another great prevention guru. Raise your hand back there. He helps us out a lot. Round of applause. Great. Okay, good. So I'm going to start off with a pre-test. So the most important way to prevent the transmission of Lyme is to have guinea hens. There's a lot of good data on that. During your Hamptons vacation, only go sailing and don't go near any grass. Letter C, do frequent tick checks and reapply repellents. D, don't follow insecticide directions. Or E, have kids stay inside and make memes all day. If you have teens with an internet connection, that's a hysterical joke. It's the hottest thing right now. That label up there, you see that yellow and black label, is what we are seeing more and more on different repellents. So whatever repellent you pick, Dr. Campbell talked about the 5 major ones that we're using now. You can't apply DEET at 7 a.m. and expect at 7 p.m. it's still effective for you. So I don't have time to go over each and every repellent, but follow the label and use it appropriately. We already talked a little bit about the life cycle, and if anybody's going to a Hamptons party tonight, there's nothing like saying the ticks are bad because of the winter we had 2 years ago. Everybody associates a lot of the ticks we have today with the latest winter, but you have to think 2 winters back. That's the life cycle that is important. So the other thing that you heard about already is one tick can lay thousands of eggs. Think about that for a minute. Thousands. That's one of the reasons why we have such a big problem. And again, they tend to like to live on animals, but there's so many of us around, we can certainly have a good opportunity there. So we don't need to necessarily review that again. But here's the other important thing is, of course, they start off as the eggs, larvae, those nymphs. Think of the nymph as like that teenage kid that comes over and wants to eat your whole house, right? They're always hungry. Teenage kids are eating everything. And so the nymph is going to get onto animals, squirrels. Guys, don't forget birds, right? One of the reasons why the New York Post had an article last week about Lyme disease in Central Park is because that's a migrating place for birds to land, and they drop their ticks. The other reason, when you go to the local hardware store and you see my picture with a wanted ad, is because I've been insisting people get rid of bird baths, get rid of bird food, get rid of bird seed, because you could be attracting birds and then they're dropping ticks in your yard. So get rid of those things, okay? Pets. When you read my 5-page article, there's a nice section on what to do with your pets. But one of my favorite things is you go to the local store or Amazon and you get like 50 of these lint rollers. And before the pet comes in the house, just roll over the whole pet. And you're going to be surprised. You're going to find ticks that haven't been bitten. Plus, it's very cool. You've probably been at the post office and you see somebody with a lint roller clipped on their belt and their cell phone on the other side. Because I tell them every couple of hours, run the lint roller over your body. You're going to find ticks. We've already heard from 2 people that Powassan virus, it's pretty rare. Don't get too excited about it. But it has a short transmission time. So the old days of, I got a tick on me. When I get home, I'll remove it. I'm like, no, stop what you're doing and get rid of it immediately. If you haven't gotten one of our famous tick kits, I want you to pick one up and try it out. So that is the cycle. Look at that little Lego, right? Think of how small these ticks are. So again, like Anne-Marie was saying, people come in with a rash. They never know that they've had a tick on them. They're so small. Max was saying that they're the size of a poppy seed. How are you going to see that behind your leg or in your groin or behind your hair? It's really impossible to be able to see that, okay? So prevention is key, right? Because you're never going to know that you've had a tick. One of the big messages I want you to think of today, because you're getting overwhelmed with information, but if you can remember one thing, treat your shoes, okay? You buy this stuff called permethrin. I'm going to have these items out. You could look at them later. The first Sunday of every month, flip-flops, shoes, treat those first line of defense pretty aggressively with that stuff. That's going to help to reduce that initial kind of contact there. We know already we're in peak war season right now. May through July are our biggest activities. The second big message that I want you to take off is what everybody on the stage is going to review tonight. It's July, it's a Saturday night. What is everybody on the stage going to do? We're going to dust off our Harrison's Principles of Internal Medicine. It's a 2.5-inch book, and they've added a section on Lyme disease prevention. It's only 2 lines, but they say stay away from wherever the ticks are. Those tall grasses, those leaf piles, the leaf brush. So, don't walk on the side of the path. Maybe just save the hiking trip for after Labor Day or the cooler weather, things like that. So be smart. Don't get all OCD about it, where you literally see people going a mile out of the way because they don't want to walk over a cut lawn, right? I don't want to go on anything green. You don't have to go that crazy about it, but it's important to think about that. So avoid it. Also, check for ticks frequently. You might not be able to see them on the back of your leg. Use that lint roller, for example. And another thing, we could all stay here for 3 hours and just talk about prevention. So the first thing I mentioned there, when you talk to 50 people about preventing tick bites, you're going to get 50 different ideas. So look at my 5-page list, think of your activities, and pick something that works for you, but make it a layered approach. Avoiding where ticks are, putting something on your skin, putting something on your clothing, use multiple lines of defense to keep the ticks off of you. So again, tick diseases are really preventable. And that famous quote that you see on my handout, 1 tick bite can make you sick and change your life. So it's important to keep those ticks away from you. There are a few very rare reports that the CDC published on transplacental Lyme, someone with really aggressive, a woman who's pregnant with really aggressive Lyme not getting treatment. But again, like Powassan, that's a very rare thing we're not getting excited about. Another report back from the 70s said that Borrelia actually adapt to their local environment, which is why when you get a tick bite in Montauk, you may feel different from someone who gets a tick bite in West Hampton, for example. They have that kind of adaptive behavior, so to speak. So think about that. There's been a lot of interesting studies, but there are studies that show that essential oils, in addition to DEET and permethrin and all of these other types of things, are effective to the point where you see off, right? You go to somebody's house, they have salt, pepper, and off on their dining room table, right? In one way or another, right? They've even gotten into the whole eucalyptus and lavender, and there's actually some good data on using that, especially if you have little kids and you don't want to smear them with DEET 5 or 6 times a day when they're going out every weekend. So we've already heard, protect your skin and clothing. Permethrin, right? You apply it once, it's good for 7 to 10 washings, so that really works good. Keep that on your clothing. Dr. McGinty always talks about our patients that come in with duct tape backwards, the sticky side out, so as the ticks crawl up you, they kind of get stuck there, lint roller analogy. Long pants. Using DEET also, and I've got a couple of versions of that. It comes as spray and wipes and topicals and liquids. So think of where you are, use that layered approach. We already know that Powassan and many of these ticks can be a rapid transmission time. There is some data that up to 5 to 10% of Lyme can come from the tick's mouthpiece. So they bite you, they start getting a blood meal, and they can have that earlier type of transmission. Remember, if you get a tick bite and you follow our advice today and it's removed quickly, the tick is not engorged, it probably hasn't been feeding on you. So you don't necessarily have to get too excited about that. So that is another important thing that you want to remember. So you're checking yourself and removing those ticks pretty quickly. The Tickborne Disease Research Center is still waiting for our, our first marriage to occur from these lectures, because I encourage people, you're a single person, it's a Saturday night, you're going to Red Bar, you could say, I went to the Lyme disease talk today and they said I need to be thoroughly checked for ticks. So you better come home with me and do a thorough check. So eventually that's going to pan out one day. So you might need help to have yourself checked as well. One of the cool things that our center does with these kid talks is we have those little glue-on tattoos that we hide on the kid's body, and we make the parents try to find where the tick is, under here or here, behind the ear. So there's definitely some surprises there. So you're checking constantly, you're using a layered approach, you're taking my 5-page handout, putting it on your refrigerator, scanning it onto your Facebook page, whatever you have to do to remember how to use it. We've already heard that the deer is really exciting. Show of hands, who's seen deer in their yard recently? We could have a whole talk on my not-so-secret love affair with the 4-poster system and high deer fencing, but we'll get into that at another time. But it's really the chipmunks, the mice, that are really carrying the disease state. So you want to make sure that those leaf piles, brush, keep things cut around your house to really make sure that you're keeping mice and things like that away. Starting around Labor Day, I put a paper bag in my hallway, and I insist that through the winter, we save these toilet paper tubes. And we will soak them with this yellow bottle, the permethrin, these little cotton balls. And around tax day, we throw these around our yard, and the ticks, the mice will grab these little cotton balls, soaked in permethrin, bring them back to their nest, and that'll help to kill off these bad ticks. So if you run around with the toilet paper tubes and these cotton balls, and the cotton balls are there, then you probably don't have much of a mouse problem, which is good news. And you don't necessarily want to put these where kids are going to be able to grab them or snack on them, so you're putting them out of reach of little kids. But speaking of kids, I like to buy lots of things with lavender. There's good data that shows ticks hate the scent of lavender, which is why when you go to Kmart or CVS, there's no lavender soap, dryer sheets, shampoos, because people are using those to help keep the ticks off of them, okay? We're still using permethrin aggressively, but I like to take dryer sheets and shove them in my kids' pockets and in their shoes, right? Dr. McGinty and I were a few years apart in East Hampton High School, and we have kids and they're going out in the yard and we're not keeping them isolated inside. We don't want you to be fearful of the grass. We want you to be aware and be protective. So you're going to use these different kinds of approaches that way. Here's a CDC website clip where you actually see a tick moving around in the winter months when the temperature is over 40. So you're always trying to be careful, right? We're in the peak season now, but you're always keeping it in your mind in one way or another. Another interesting thing is ticks will rarely cross a 3-foot wood chip border. So you put that around your house, and that helps to prevent ticks from moving around. So a lot of landscapers will put in that 3-foot wood chip border. It's interesting, they've done studies on gravel and rock, and that doesn't seem to work as well, but it's that 3 foot. So again, the obvious stuff, we're using 2 layers of repellent. Maybe you're using an essential oil or DEET on your skin, and you're using permethrin on your clothing, you're tucking your pants leg in, you're using duct tape, you're walking around with the lint roller clipped to your belt. Come on, it's a new fashion statement, right? And you're staying away from these tall glasses, okay? And again, the newest thing I need you to tell you is look for that black and yellow label and use these repellents aggressively. And you know what? It's going to come up later in the questions. Jerry, I'm afraid of permethrin. I'm afraid of DEET, and I don't want to use those things. And my answer always is an occasional exposure to these things are better than ending up seeing Dr. Mineroff in the ER or having Dr. Coyle try to figure out why you can't add your checkbook and you've got strange spinal pain. So an occasional exposure is mitigating these bigger kinds of risk factors. We've talked about questing, and rubbing up against grasses is a high-risk time, and certain ticks will smell you, that carbon dioxide plume we talked about, and you're like, how do I get a tick on my lawn chair? I'm like, well, they're probably following that scent. And also, please don't let your dog sleep in your bed. A lot of the repellents that a vet use makes the tick not happy when it bites the dog. So if it tries to bite the dog and it doesn't like it, it's going to fall off, okay? And it's going to be inside of your bed that way. We've talked a little, we've talked a little bit about safe removal, but that hypostome, basically that little mouthpiece you see here, can get stuck in you and cause that 7-month itch, right? Has anybody ever had a tick bite and like it just doesn't stop itching? That's that little piece left in there. So one of the things we'll do when we remove a tick is we use a little tiny skin biopsy and just kind of take out the skin with that little mouthpiece, put a Band-Aid on it, and it heals, okay? When you do remove a tick using our tick bite kit back there, you can use, of all the things out there, I like good old-fashioned World War II iodine, right? We use iodine in different ways in the OR to clean the skin. So I say put this on thick, brown color, and reapply it every couple of hours. Keeping that skin brown is going to help to kill any germs that might be on there. So you get an old-fashioned bottle of iodine like from the medicine shop. Pets, there's a whole section for you to read on pets. Ask your vet. Cats tend to not do very well with chemicals. So what I want you to remember today, use the lint roller and keep them out of your bed, right? So just a few final thoughts, right? Prevention is key. Harrison's internal medicine. Stay away from where the ticks are. Treat your yard. Remove ticks immediately, right? Treat your yard. Get rid of brush. Get rid of leaf piles. 3-foot wood chip border. Good. We're going to get to that. Well, there are natural sprays. There are chemical sprays. That's what Brian helps us specialize in. Get rid of your bird bath and all of those different types of things. Keep your lawn cut short. Guys, in the summer of 2017, a semi-brown lawn is kind of a fashion statement. When you're watering your grass and making it moist, you're attracting things that you might not want to be there. Plus, who wants to mow all summer anyway, right? You may have a tick bite and never see it. Look out for the summer flu, right? And like Anne-Marie already said, if you have a rash and symptoms, you don't necessarily need a lot of blood work. Just one other point, as we said, if you have a rash and you want to help us, come in, let us take a biopsy of it. If you're just fluish and not happy, in East Hampton, we're working with what's called the Lyme Disease Biobank, which is a big think tank in San Francisco, where they take samples of people who don't feel good in endemic areas to study them, both healthy controls and people who are sick. So you're going to treat your yard, you're going to check yourself often, maybe you're going to have a hot date and get checked tonight. There are lots of different repellents you can use. I have a chart that's included on there. There are at least 4 or 5 studies that show eucalyptus, lavender, and all of those other alternative things actually have some pretty good data to it. So I'll wrap it up, and I think maybe we have everybody stand for like 30 seconds before the Q&A phase, because I know you've been sitting for a while. Great, thanks.